allow me
And
to
he says,
start?
yes, I think you can start to share
Okay.
your screen until he joins on screen.
Okay, so can you see my screen now?
Yes.
Yes.
Okay, so my title is a little bit different from IHAB and goal is titles because I'm stressing my lecture on the surgery of craniocervical and upper cervical lesions, including the intradural extramedullary lesions, especially doing this surgery through the lateral approach. I have nothing to disclose, and this is my last publication about the far lateral approach for upper cervical meningioma. It was in the Asian Spine Journal last few days. And intradural extramedullary pathology are not uncommon pathology. They are mostly slowly growing and benign, and they usually involve a few spinal segments. And more than 50% of the meningioma in this area is anterolaterally located. That's why we are studying the lateral approach. The differential diagnosis could be a neurofibroma, schwannomas, meningioma, some rare cases like lipoma, dermoid, epidermoid, teratoma, and also metastasis, which is very uncommon, like leptomeningeal metastases or droplets from intracranial, like medulloblastoma or ependymomas. The meningioma is 10 to 20% located in the cervical spine and only 2% in the foramen magnum. And they are 5 to 10 times more common in women than men. And 7% of these are intradural purely. 6% are mixed between intra and extradurals. And we see in these cases not infrequently. 2% of meningioma are multiple. This is part of neurofibromatosis 2. And typically they are globoid, and more than 50%, as I said, is anteriorly or anterolaterally. And they have broad base attachment to the dura, and this is very important during surgical techniques. In terms of neurofibroma and schwannomas, these are benign nerve sheath tumors, typically arise from the dorsal roots, the sensory roots. And neurofibromas are fusiform, maybe multiple, while schwannomas are solitary, eccentric from the nerve sheath. And 30% have an extradural component, what we call the hourglass or dumbbell tumors. And prominent CT and MRI enhanced disease characteristic for these schwannomas, and also CSF protein is elevated, and this could be clarified from the meningioma in which the CSF protein is not erased. Clinically, the clinical presentation of these tumors is a mix between myelopathy and or radiculopathy. In nerve sheath tumor, usually radiculopathy starts before myelopathy, and the opposite with meningioma, where the myelopathy starts before radiculopathy. And this neurology could be increased or be deteriorating to a Brown-Séquard syndrome. And sometimes we see cases of this benign, slowly growing lesion with complete cord transections. We've seen this many times, unfortunately. The investigation, still X-ray have some role, especially if you have a schwannoma that's going through the foramen transversarium and opening the intervertebral foramina. However, the MRI is the first choice in the diagnosis. The multi-slice CT scan is very important. Sometimes if you go to, if there is some bone changes or bone erosions, and which is rare. Angio is important also to see the vertebral artery around this area, and maybe CSF analysis to differentiate schwannomas from meningiomas. The perioperative treatment may be a controversial issue or the controversial role of steroids, but yes, it has some rules. And the aim of surgery is total excisions. The standard approach of this lesion is the posterior, and this could be a laminectomy or sometimes laminoplasty. The lateral approach, the approach that we are going to present this evening, and the anterior approach was very, very rare doing for these kind of lesions. If you have a lesion with extra spinal extension now, either you extend the initial laminectomy laterally to remove the extra spinal extensions, or do it in another separate surgery, and this is also our rare occasions. And this is the how we can approach this part of lesions. And general tricks is to remove the dentate ligaments to widen your axis. Also, if you have dorsal roots, it can be removed. Usually, these are non-functional. And the dura, if you have a dura, either you cauterize the dura or you remove it to make a total and avoid the early recurrence of these lesions. And if you have a spinal deformity that is already present or increased by your surgery now, you have to consider fixations. This is Professor Shiger in 1999. He demonstrated the 6 variations of the extreme lateral craniocervical approach. And our approach we used is a transfacetal approach, but we use it as a retrofacetal approach. And this is the approach that is being shown here. And as it is a retrofacetal approach, this is the position of the patient and the incision. And this is how we go through the retrofacetal approach. If you put the patient in the lateral position and you go between the scalenus anterior and the trapezius muscle posteriorly, and with finger dissections between the muscles and feeling the lateral mass of the cervical spine or the facet joint, and you just do a subperiosteal dissection of muscle from the lamina and the spinous process. Now you are there here. Deeply, you find the muscles of the posterior triangles, and you have to remove these muscles in order to expose the C1 and C2 or C3 and C4, depending on the pathology. And finally, you get here with exposure of the bone. Usually, the people are worried about mobilization of the vertebral artery. And as I said, my approach is a retrofacetal approach because the intradural tumors usually is okay to go by the retrofacetal approach, just doing a hemilaminotomy and opening the dura, and no need to manipulate the vertebral artery. Only the vertebral artery is needed to be manipulated in different another variations of Dr. Shiger, as it said. But this is only in bony skull-based tumors, because the vertebral artery is indulged and is found between these bony tumors. This is my study, which is a descriptive retrospective clinical case series to evaluate the lateral surgical approach in upper cervical intradural tumors. And we included only patients who underwent lateral upper cervical surgery for anterior or anterolateral either meningioma or schwannoma through the last 7 years. And these are the variables that we evaluated during our surgery. And we use the GOA scale to clinically evaluate the patient, and all patient has plain radiography and MRI, and they were followed up routinely at the outpatient clinics. So far, we have 23 patients. The mean age was 46. Most patients were females, and the preoperative symptoms duration was about 15 months, and the pathology was 14 meningioma and 9 schwannomas. All patient has lesion anterior or anterolateral to the cord between the occiput and C4, because below C4 level, we can't apply this lateral approach, because C5 and 6, the shoulder will hinder your lateral approach, and it's better to stop at C4 lesions. Operative time about 2 hours. Blood loss. Usually, we don't transfuse blood for this kind of surgery, because if it is done cleanly, it can be bloodless surgery, and hospital stay from about 4 days. As we see, most patient was clinically grade 1 according to the GOA scales. And this is some examples. If you look here, this is a C1 meningioma, and you can see from the axial cuts here that the lesion is anteriorly to the cord, and also from the coronal, the lesion is coming from one side. Now, how to look topographically at these lesions? If you look at the bottom picture here, and you see the orange line, you can see that the tumor is anterior to the cord. And if you go from behind, you have to work and manipulate the spinal cord. But if you go from the lateral, you go direct and see the tumor and remove the tumor without seeing the spinal cord. Again, another case of C1-2 meningioma. And if you look also at the topography of the lesion, you can see that the lesion is anterolateral to the spinal cord. And if we went from the lateral side, we can do it safely without any manipulation. The other issue also is that the midline structures, the ligamentum nuclei and interspinous ligament, all these structures are kept intact. So we don't disturb the upper cervical segment instability. Another case of C2 meningioma, and it can be done through the same approach. And if you look here at the end of surgery, you can see that the tumor has been removed and the cord is covered by the dura, and this is the contralateral dura sigmoid. Also, CT through meningioma can be done through the same approach, and this is an example of foramen magnum lesions. It is anteriorly located to the spinal cord, which is completely smashed by the lesions. And if you look through the upper surgery, this is the skin approach, and this is after exposure of C1 and occipital bone. And we have removed some part of the occipital bone here as C1 only through the lateral approach. And this after exposure, you can see the tumors here, some sensory roots, and the dura covering the spinal cord. So we don't see the spinal cord until we finish the surgery. If you look here, after a complete removal of the tumor, there is only a small piece here of tumor that was attached to the vertebral artery that left inside. And if you look at the postoperative, you can see this is the small part that left there, and this is the pseudomeningocele that will be resolved after surgery. And the spinal cord and medulla is completely decompressed. C1 meningioma, same approach. You see, you can remove it from here as one piece, and with the postoperative X-ray, there is complete tumor removals. And this is the pseudomeningocele here after removing the tumors, and this is normal finding at the early postoperative. This can be applied also to a C1 meningioma through the same approach. And C2 meningioma, look at this dumbbell-shaped C2 meningioma. It is anterior to the spinal cord, again smashing the spinal cord posteriorly. And if you look here, there is an intradural and extradural component, large extradural component here, and this all is purely anterior to the spinal cord. If you went from the standard from the back, you will face the cord before seeing the lesions. Look at different images, and this is the our surgical approach. A linear skin incision, finger breadth behind the depocyte process. After bony exposure, you can see here, this is the facet of C2, lamina of C2, remain of C1 arch here because it was very thin, and this is the extradural component. And if we open the extradural component here, look, we removed the C2 lamina and the thinned out C1 lamina, and this is the dura, and this is the extradural part. So we remove the extradural part first, and then we open the dura to see the intradural lesion. As you see here, there is no spinal cord in the field. You can just remove this safely without any manipulation. There is no spinal cord in the field. It's 100% safe. And this is after excision. And you can see the contralateral dura purely and clearly after removing the tumor. And the spinal cord is completely covered by the dura posteriorly, no C. The outcome of our cases is very nice. All our patient has improved at least 1 grade according to the GOS scales. We don't have any case, a non-case of deteriorations or any morbidity apart from some cases of CSF leak into the drain. And in case of this, we just leave the drain inside until the CSF stops, or after 1 week, we can remove the drain without any wound CSF leak, just CSF leak inside the drain, not from the wound. My take-home message is lateral cervical approach is a safe and direct and effective access for these lesions, and it allows direct access to tumors without risking cord manipulation or destabilizing the upper cervical spines. It gives the same clinical result and more safer than the standard posterior approach. And we advise that spinal surgeon should be familiar with different surgical ecstasies to manage different and various pathologies. Thank you very much.
Thank you, Professor Ali, for this great talk. I think Professor Atul Goel already joined the meeting again. On behalf of the IT company, which is running this webinar, I would like to apologize for everybody for this technical problem, which led to disconnection of the meeting for a few seconds. Goel, are you here? Professor Goel?
Yes, I'm here.
Okay.
Can you hear me?
Yes, we can hear you. Would you share your screen again, please?
Okay, just a minute. I'm having some problem in sharing my screen. Just a minute. Can you see my screen now?
Yes.
Yes.
Just a minute. There is some. Okay, just a minute. There is some problem in sharing my screen. But you know what? In the meantime, whilst my screen is running, I will like to have, whoever wants to ask any question can,
Yes. Abdul Hafiz, you have a question already.
Because, screen is having some problem. You can see the ring going.
We can see the screen, but you are not turning the slides.
No, it is, there is some problem. I'm not able to open it. Just a minute.
Okay, well, take your time. Well, no problem. Professor Abdul Hafiz, are you here?
Yes, I am here.
Would you like to make discussion until
until my because go ahead.
Yes, would you like me to discuss with Dr. Ali Abu Madawi first for his talk? So
yes, please.
Till you prepare yourself, Goel.
Yes.
My friend.
Hello, how do you do? Actually, thanks for your very nice and precise presentation. Of course, a lateral approach is needed for in many occasions, but I would like to ask about your cases. I can see that many of you, the tumors, except the one case, that really you are in need for lateral approach, because there is always what's called tumor surfacing, and you need only just 4 or 5 millimeter of surfacing of the tumor to get inside it, and you can go to the tumor and its blood supply, and you can remove. So I don't know what's your opinion, because it is not that not all the cases are in need for lateral approach, only maybe 2 or 3 cases. The second point is that also I have to criticize you about is the gross total excision of the tumor. I mean, for especially for youngs that they are with us, these tumors in these eloquent locations and very dangerous neural tissues, we have to take it a piecemeal, and not the tumor as a whole. You excise it, even if it is possible. I will not do that. I have to do it piecemeal removal. What's your opinion about this point?
Yes, two nice points, Hafiz. And I can tell you that Dr. Goel has an article in Neurosurgery, Journal of Neurosurgery, years and years ago about anterior and anterolateral meningioma. He actually, at that time, he published 14 cases, I think, and he presented a very nice outcome comparable to the anterior approach from behind. He operated totally for anterior and anterolateral meningioma from behind with very nice outcome. I can assure that if you know the lateral approach very well, which is more or less standard, I can say it is ordinary approach. It's more safer, especially for fixed meningioma, anterior meningioma, and some anterolateral meningioma. You don't disturb the midline pathology, the midline structures, and you can't see the tumor directly. And if I can do it posteriorly and laterally, I would do it laterally. And I don't object you if you do it from behind, but I would risk the cord at least a little bit if I do it from behind. This is one point. The other point was, what's the other point, Dr. Hafiz?
The other point is piecemeal removal
Piecemeal, yes,
versus,
yes. Yes, piecemeal, yes. If you're doing this from behind, you are obliged to do it piecemeal to deliver some tumor and some tumor and some tumors. This is an obligation for posterior approach. But if you're doing a lateral approach, you can see directly, especially if it is not big tumors, you can see directly the origin of these lesions, and you just cauterize between these lesions and the dura, and you can deliver it peacefully, safely from the lateral approach. This is not, it cannot be applied to the posterior approach. It's applied only to fairly small lesions and from the lateral approach. You can do this. But if a posterior approach, even if it's smaller, small lesions, you can do this way. You have to do it piecemeal. Yes, you're right.
You have a spare minute for me, or shall we start after Goyle? After
Yes, please, Professor Osama. Let me ask first, Goel, are you ready?
Yes, I'm ready completely.
Okay.
Okay.
I think Professor Osama, after the talk of Professor Goel, we can make discussion. Okay.
Okay. Thank you.
Okay, gentlemen, I can see Ehab now a little bit. Now, before I didn't see him, now I can see him. And I'm happy to see Ehab.
It's my great pleasure. It's my great honor, Professor.
Thank you. Thank you.
You taught me the spirit of Cranio Cervical Junction.
Okay. So now you
was
see
1 month, 1 month fellowship in your hospital. It changed my life about Cranio Cervical Junction. Changed my surgical philosophy toward this region. It was the important month in my life.
Thank you, Ehab. Now you see, Ehab, if you can do craniovertebral junction properly, you can give this beautiful smile to our patients. And you can give a beautiful neck to our patient. You see the neck? So not only neck, and you can give hands, and you can give life, you can give legs, you can relieve him of pain, you can give him absolutely new life if you can do craniovertebral junction fixation. So that is the spirit of this operation. So you see this another patient, he had a smile before, but he does not have a smile here. But his neck has become long and his neck has become straight. You see this kind of basilar invagination and this kind of atlantoaxial instability, this short neck, this torticollis are reparative. These are protective, nature's protection. And you stabilize, and then the neck becomes long. And you see, when there is a trauma, you get spasm of the neck. But in long-term atlantoaxial instability, chronic atlantoaxial instability, there is this kind of torticollis, short neck, bone fusion, assimilation of atlas, C2-3 fusion. There are several other problems. So atlantoaxial instability is the mother of problem. It is the origin of problem. And all other things are reparative or secondary issues. You see, there is a short neck, and you do atlantoaxial fixation, and you see there is a long neck and there is a straight neck. There is no decompression, and there is no occipital fixation, only atlantoaxial fixation, even when there is assimilation of atlas. This is another case. You see, there is quite a bit of problem and rotation, and there is a stabilization. So in chronic atlantoaxial instability, nature, God plays a very big role in reparative. So all these things are like short neck, torticollis, platybasia, bone fusion, clipal file abnormalities are all secondary. You see this neck, and you see this straight neck, and this is in the immediate postoperative period. On this picture has been taken after second or third day of operation. You see atlantoaxial. So atlantoaxial instability is the mother, is the origin of all problems. This is another, you see this boy looked like a hero before the operation, and after the operation the hair is gone, but the neck has become quite straight, and also the smile has become a little bit bigger. There is basilar invagination. The problem is atlantoaxial instability and the treatment is atlantoaxial stabilization. So cervical fusions, Klippel file abnormality, assimilation of atlas are all protective. They are secondary to craniovertebral junction instability. So that is my concept. My concept is that all kinds of bone fusions are reparative or protective mechanisms. You see, there is multi-level bone fusion. There is no compression at the craniovertebral junction. But my concept is, you see, there is some instability at the atlantoaxial joint. All these problems like increased CSF here, increase in the spinal canal, bone fusions. This lady was a very high profile. She was a daughter of a very big politician, and she was not able to breathe before operation. And you see the short neck. And if you are able to do atlantoaxial fixation, this girl got an absolutely new life after the surgery. And we have to understand that there is no need to do any kind of osteotomy here, but there is a need for atlantoaxial stabilization. Another beautiful concept we put forth is that the bifid anterior and posterior arch are, they are dynamic. You do flexion, the bifid opens up. You do extension, bifid closes. So there is an opening and closing of bifid. And this bifid is not like spina bifida of lumbar spine. This is a dynamic process. So when there is a bifid atlas, bifid arch of atlas, it moves, it opens and closes. And the need to do is to do atlantoaxial fixation. When there is multi-level spinal fusion and there is a bifid anterior and posterior arch, the problem is atlantoaxial instability and there is a need to do atlantoaxial stabilization. Os odontoideum, I published a series of 190 cases. Os odontoideum is also an indicator of atlantoaxial instability. So when there is os odontoideum, there is atlantoaxial instability and you do atlantoaxial stabilization. There is no need for transoral decompression. There is no need to include occipital bone. There is only atlantoaxial stabilization is the treatment. You see os odontoideum, there is, you do stabilization and the os odontoideum, this cyst also disappears. There is a cyst. This is immediate postoperative disappearance of this cyst. So atlantoaxial instability is the problem. Syringomyelia is a secondary phenomena. It is a neural translation. It is a neural alteration in the presence of atlantoaxial instability. So there is no need to do there is no need to do syringostomy or syringosubarachnoid shunt or any kind of manipulation of syrinx. Syringomyelia is a reparative or natural protection for one problem, and that problem is atlantoaxial instability. Now I want to introduce one revolution in craniovertebral junction, the concept of central or axial atlantoaxial instability. So now you see this. This is a new concept, central atlantoaxial instability. Carefully look at this slide where I'm showing the facet of atlas is in front of facet of axis. There is increased atlantodental interval. There is a facetal listhesis and a facetal stabilization is the treatment. Now look at this case, there is basilar invagination. There is no atlantodental interval disturbance. There is syringomyelia and there is Chiari malformation. Now you carefully see here, the facet of C1 is behind the facet of C2. This is an unstable spine and this patient needs atlantoaxial stabilization. I can tell you the whole world will do foramen magnum decompression and syringostomy, but that is not the correct form of treatment. Now you see another beautiful thing. There is no atlantodental interval disturbance. There is no facetal malalignment, but the presence of Chiari and syrinx are indicators of an unstable craniovertebral junction. And it needs stabilization. And you see the syrinx is gone. There is no need for anterior decompression or posterior decompression. This is an unstable spine and you need stabilization, and you need to stabilize atlantoaxial joint. Now I will show you several cases. You see, you have seen this kind of dislocation, C1 over C2. This is type 1 dislocation. And you need to do stabilization in presence of Chiari and syrinx. There is no question you don't need to do craniovertebral junction decompression from front or behind. You need to do craniovertebral junction realignment. Now you see, this is another kind of C1 facet is behind the facet of C2. It is an unstable spine and you need to do stabilization. This is basilar invagination with Chiari and syrinx. There is no tight posterior fossa. There is a facetal malalignment type 2, and this patient needs stabilization. This patient, you see, there is a huge basilar invagination. There is no atlantodental interval disturbance, but there is a big facetal malalignment. It needs atlantoaxial stabilization. There is no need for decompression. And I can tell you, this patient will get a new life after surgery. You see, there is atlantodental interval disturbance. There is the facets are in malalignment. There is no need for decompression in this situation. What you need is to do stabilization and the syrinx will disappear. And more importantly, the patient will improve. This is a case of Chiari malformation. There is no atlantodental interval disturbance. There is no facetal malalignment. This is an unstable spine. You need atlantoaxial stabilization. There is basilar invagination. There is assimilation of atlas. There is a very difficult operation of atlantoaxial fixation. If you can do fixation, believe me, you give absolutely new life to this patient. So there is Chiari, basilar Chiari malformation, no atlantodental interval disturbance, but there is a facetal malalignment. Now I will show you. So it means that basilar invagination is always associated with instability. And whether there is group A or group B, I have published several cases of basilar invagination treated by only atlantoaxial stabilization without decompression. So this is my concept. Basilar invagination is a musculoskeletal alteration in cases of chronic atlantoaxial instability. Syringomyelia and Chiari malformation are neural alterations. Chiari malformation is treated in the literature by various kinds of decompression, by foramen magnum decompression, tonsillectomy, dural decompression, and several other forms of treatment. So in the year 2014, I published this paper that Chiari malformation is due to atlantoaxial instability. This is secondary protective neural translation in the presence of atlantoaxial instability, and atlantoaxial stabilization is the treatment. So let me show you several cases. You carefully look at this and you will see this is Chiari malformation, syringomyelia. There is facetal malalignment. You do atlantoaxial fixation, the syrinx reduces and the patient improves dramatically. No atlantodental interval disturbance, little bit facetal malalignment. There is basilar invagination and there is Chiari malformation and syringomyelia. You do atlantoaxial fixation, magic, immediate postoperative magic. And many a times the syringomyelia will reduce in the immediate postoperative period. There is no decompression, no tight posterior cranial fossa. So when there is Chiari malformation, no atlantodental interval disturbance, no facetal malalignment, you have to do atlantoaxial stabilization. So carefully see several cases I'm going to show you. There is syringomyelia, there is Chiari, there is no tight posterior cranial fossa, and there is no problem in the atlantodental interval. There is no facetal malalignment. I have done atlantoaxial fixation and there is reduction in the size of syrinx. There is no decompression of any kind. Chiari malformation, big syringomyelia. You see there is no atlantodental interval disturbance. You see the syringomyelia has reduced and I have done no decompression and atlantoaxial fixation. So I published this and said that Chiari malformation is not a malformation. It is a natural formation, and it is like an airbag. When there is a potential instability, these airbags come in picture to protect. Similarly, Chiari malformation is a formation and it is a protection. So just see this case now, syringomalia, Chiari, there is atlantodental interval disturbance, no disturbance, and there is reduction in the size of syrinx. So I have got now several hundred cases of such form of treatment where I have done only atlantoaxial stabilization. Now you see preoperative here, the syringomalia has reduced in the immediate postoperative period. So whether syringomalia reduces or not reduced, that is not the issue. Issue is the patient improves remarkably in the symptoms and the person is cured, completely cured. So Chiari malformation always, not sometimes. Atlantoaxial instability is the cause and atlantoaxial stabilization is the treatment. When there is a tumor and syrinx, that is a different problem. When there is hydrocephalus and Chiari, that is a different problem. When there is lumbar spina bifida and syrinx, that is a different problem. I am talking of this kind of Chiari malformation and syringomalia. Atlantoaxial stabilization is the treatment. This is preoperative and postoperative. You see the syringomalia has reduced. This is no atlantodental interval disturbance. There is some facetal malalignment and atlantoaxial treatment. There is no problem here. There is no facetal malalignment. There is a big syringomalia, Chiari malformation, basilar invagination. You see the syringomalia has reduced and there is no decompression. So when I wrote this article, many of you know, and many of you have visited. I can see some faces in the gallery where many of you have come and seen me. And to answer my question, I had to write various articles in the literature and various letters to editors saying that we don't believe this and we don't agree with this. But believe me, my dear friends, this is a new introduction. This is a revolution. And there is, I am not talking on the basis of more than 400 such cases. And there is no question that Chiari malformation is a manifestation of atlantoaxial dislocation and you need to do fixation. Even when there is no basilar invagination, there is no question. Even when there is no basilar invagination, atlantoaxial fixation is the treatment. I published this case series some years ago. So when there is no basilar invagination, there is Chiari and syrinx. You see the facets may be abnormal. Even when the facets are not abnormal, they need stabilization. When there is no bone malformation, there is no basilar invagination. You see the facets are malaligned. There is Chiari and syrinx. You do fixation, the syrinx will go. I am again repeating, whether syrinx goes or not, it is not a matter, but the patient will remarkably improve in the symptoms. There is no bone malformation. There is no facetal malalignment. The syrinx has reduced following surgery, following only fixation. Syringomalia, Chiari malformation, there is no basilar invagination. You see facetal malalignment. The syrinx has reduced and there is atlantoaxial fixation. So you see there is another case, syringomalia. There is no atlantodental interval disturbance and I have treated by only Chiari without syrinx. You see the tonsil has regressed. Whether the tonsil goes up or not, that is not the issue. You do atlantoaxial fixation, the patient remarkably recovers. This is another case where the syrinx has gone down and I have done atlantoaxial fixation. This is another case of syringomalia, Chiari malformation. You see the facetal malalignment. You do atlantoaxial fixation. Essentially what I am saying is, for Chiari malformation, decompression is not the treatment. It is a manifestation of atlantoaxial instability, and it is the treatment is atlantoaxial stabilization. You see the syrinx. You see this is another case of atlantoaxial stabilization. Normally for these cases, the whole world, I'm not sure what EHAB will do in this case, But here, don't do decompression. There is no tight posterior fossa in Chiari malformation. You do, even when there is no facetal malalignment, you have to do atlantoaxial stabilization. This is
Yes,
another case.
I
You see
started to
big
do
syringomalia,
fixation.
and there is syringomalia has gone. And as I have mentioned to you, I have got more than 400 cases recently. I have written one paper in World Neurosurgery about my current experience. These are not easy operations. You see the syringe has gone, and this patient came with 6 nerve weakness. You see when she's looking here, the eye is not moving. Chiari malformation, basilar invagination, facetal malalignment. I do fixation, and in the immediate postoperative period, the 6th nerve recovers. So this, and some patients, I have got now many patients, even from Egypt, I have got one patient where foramen magnum decompression was done. And foramen magnum decompression for Chiari malformation, syringomalia, and the patient has lost her voice. And I do fixation, and the syringomalia reduces, and the patient recovers remarkably. This is another case where the patient was operated 13 times. Syringostomy, foramen magnum decompression, repeat foramen magnum decompression, and then I do this treatment. And also, this is another case where this patient was also operated several times, included shunt operation and various kinds of treatment. Then I did atlantoaxial fixation. You see the syringomalia has reduced, and the patient had come in a miserable condition. This is when he was being discharged. You see, the Riles tube has been removed, the catheter has been removed subsequently, and the patient has absolutely fantastic new life. This was a very intelligent man and was treated by several operations, and this is the new life the patient has gone. When I wrote the paper page, many people told me that this does not work in pediatric age group. But I have then subsequently written my experience with pediatric patients in 33 patients, and there is no question. This is a child of 7 years old. There is Chiari and syringe. I did fixation, new life, absolutely new life. This is the child. This is preoperative, and this is post-operative. You see, he had in 3 months after operation, and you see he is in my hand and now running and new life. So this is another child with syringomalia and Chiari, and this is fixation. So atlantoaxial facetal malalignment is a big thing in Chiari malformation. Whether they are malaligned or not, you have to do atlantoaxial fixation. So that is my concept, which I am putting forth in front of the Egyptian Society today. So chronic atlantoaxial instability, there are many manifestations. So syrinx is one of these manifestations when there is syringomalia without Chiari malformation, idiopathic syrinx. So do not treat this patient by syringostomy and all those things. You do atlantoaxial stabilization, and you see the absolutely fantastic result of stabilization. Spinal kyphosis with Chiari malformation, nobody knows how to treat. So there is kyphoscoliosis, and there is Chiari malformation and syringomalia. Many people do decompression here, some people do stabilization, but that is not a good form of treatment. You do atlantoaxial stabilization, and you see this, there is a big kyphoscoliosis, and this is after 2 months of surgery. The kyphoscoliosis has remarkably reduced, and this patient has completely, and I published this series with only atlantoaxial stabilization. So atlantoaxial stabilization results in treatment of kyphoscoliosis. What I identified is during operation, the MEP potentials can improve during operation. That is another beautiful thing, and I published this in World Neurosurgery. So this is the case. I did fixation, and if you are good in neurophysiology during operation, the MEPs have recovered. So atlantoaxial instability is a very common problem, not common. It is always associated with atlantoaxial instability. And I want to introduce another concept that when there is chronic atlantoaxial instability, there may be Chiari, there may be bone fusion, there may be assimilation of atlas, there may be bifid. So whatever is present, even if there is only bifid, it indicates atlantoaxial instability. If there is only short neck, it indicates atlantoaxial instability. If there is only torticollis, it indicates atlantoaxial instability. So there is a central or axial atlantoaxial instability. You see, this patient has no atlantoaxial instability, but there is a bifid. So bifid indicates atlantoaxial instability. You stabilize and you give this smile, and you give this smile to this doctor. So I am now saying, can foramen magnum decompression surgery become historical? I am saying absolutely. So now I will wait for a few questions, then I will go for the second. My second, I want to show one, let me show you the technique, okay?
Okay.
Nasir, is it okay?
Yes, of
I'm
course.
going to show you one case. Show the vertical.
Very good.
Wait. Just let me first, get out of this. Just a minute, please. I want to show you one case, okay?
Okay.
So now I do this operation under traction. This is Gardner-Wells traction. And I put it after anesthesia. Then I turn the patient. You see, when I turn the patient, I am holding the neck. You see, holding the neck. This is a very heavy patient. So you hold the neck and turn the patient, okay? And then you give head high position, head high, under traction. There is a traction. And if you realize the head is floating, it is not, it is just touching very, you see this headrest is, the head is floating. It is not actually touching. It is just touching. It is not, this is a case which I had done long time ago. Then I take midline incision. And if you know my technique, Ehab may be knowing that my operation does not involve coagulation. I do not coagulate in any operation. Bipolar coagulation is only one if it is required, but bipolar is also very less. So I feel the C2 spinous process. This is up, this is down. This is the C2 spinous process. Then I do sharp dissection over the lamina of the C2 spinous process and lamina. Now carefully look at this. And my dissection is sharp and subperiosteal. And this is almost, this is unedited, almost unedited. Sometimes I finish this operation in 45 minutes and sometimes in less than 45 minutes. Sometimes I do 2 cases a day and sometimes I do 5 cases a day. And maximum is 6 cases a day of craniovertebral junction stabilization. Basically what I do is I do it quick. And you see, this is, I'm trying to go to the C1, C2 articulation. Just carefully look because this is not much edited. This is, now I have exposed the C2 ganglion. If you see this, this is C2 ganglion. I normally do not cut the C2 ganglion now. See, C2 ganglion is a large ganglion located right behind the C1, C2 articulation. See, I go along the pedicle into the articulation. I'm trying to mobilize. Normally, nowadays, I mobilize the ganglion. This is the large C2 ganglion. I'm cutting it here, but I must tell you nowadays I don't cut C2 ganglion. And if you cut C2 ganglion, you get paresthesia and numbness in the suboccipital region, nothing much. You can cut the ganglion if your exposure is not good. Now you see here, I am entering into the C1, C2 articulation. Just see this. This is the C1 facet. And I'm not sure if you are realizing there is no coagulation in this operation of mine. Very rarely I coagulate here and there, but you see now I have opened the joint. You see that? I've opened the joint and I'm turning the osteotome and facet. You see, this is the C1 facet and this is the C2. Now I'm exposing the C1 facet. You have to have a very big panoramic exposure. Venous bleeding can be quite furious in this area. So if there is venous bleeding, you have to hurry up your operation. And you have to introduce this kind of Surgicel and gel foam here and there. Now you see the whole thing is in front of my eyes. The facet, this is C1 facet, this is C2, and I am plugging some Surgicel. Normally I don't even plug this Surgicel here and there. It is not necessary. You put some gel foam. Now I will prepare this area for C1, C2 fixation. You can come to this point in 15 minutes or 20 minutes. Now I'm putting bone graft in the articulation. You see this? I am putting in the C1, C2 articulation lot of bone graft. And this is very important step. If you don't do this, I will say there can be chances of failure. Then you do not blame the concept that no, fixation doesn't work and all those things. If you do not do it properly, it will never work. And in proper, if you have to do it properly, you have to open the joint, you have to introduce the bone graft in the facet in the C1, C2 articulation. Now I will prepare my region for stabilization and instrumentation. You see, this is the, here if you see, this is the C2 spinous process. I'm drilling this area to introduce my plate. You can also use polyaxial screws and rod if you want to, but I like to use plate and screws, which you will see. I'm drilling the C2 lateral aspect of the lamina to make space for my plate. Now you see here, this is the C1 facet. My bone graft is in the articulation. Then I'm making a hole in the C1 facet. You see that? I'm making a hole in the C1 facet for my screw implantation. And this is not an edited version. You must remember, this is not edited. This is unedited operation. Many a times I do more than 2 or 3 or 4 cases in a day. Sometimes maximum, I have done 6 cases a day of craniovertebral junction stabilization. I did live surgery workshop where I did 4 cases in a live surgery workshop where there were several people from all over the world. So I moved the plate over the part which I had drilled. Now I make a hole very medially on the pedicle, and it goes in the facetal articulation. You see now here, I am making the hole very medially, very medially. And if you see the vertebral artery in a normal situation, you see here in this drawing, my screw direction is going superiorly like this. Inside the pedicle and into the facet. Then I move the plate. Then I do stabilization. It is very important to do full operation. Like full operation means open the joint, denude the cartilage, introduce bone graft, and then do metal fixation. These are titanium plates and screws, and these are actually self-tapping screws. These are 26 to 28 millimeter in their length and 2.6 to 2.8 millimeter in their diameter. I do not use very big and very large diameter screws. So once you have tightened, then I will show you the last part of the operation, which is also, then you repeat the steps on the other side. Now I have done the operation on the other side and I have moved ahead. You see, this is right side, this is left side. Then, then another very important step is to remove all the muscles of the C1 arch and all over the C2 spinous process. And drill very elaborately on the C2 spinous process and on the arch of Atlas. Very big drilling has to be there. And then you have to put bone graft here. You see, this is also one very important step. Otherwise, these muscles can break your implant. See how much bone graft I am putting here. Lot of bone graft, and then I do fixation. Now, what I want to do is I want you to ask me if you have any question, then I will move on to my second part of my lecture.
Thank you,
yes.
Professor Goel. We have many questions for Professor Osama Al-Ghanem.
Yes,
Professor
yes,
Osama Al-Ghanem, let me introduce you first. He is Honorary President of the Egyptian Society of Neurosurgery and former Dean of the Faculty of Medicine at Azhar University. Please go ahead.
Yes, hello, Professor Goel.
Oh, yeah,
we haven't seen you for 20 years ago, and I met you in Mumbai as well before, 20 years ago.
I know. Well, I have seen, you are my good friend for a long time.
Thank you. Well,
I'm happy to learn that you are now the dean and director and a very big man.
well, not very. No, I'm a very humble man.
At that time, you were a little bit younger and your hair was a little bit darker.
Well, we are the same. You lost your hair and my hair become gray. No problem. Well, I think I admire your work, but you see, you gave me the concept that you are inventing a magical solution for searings, for scoliosis, for anything, and not doing any compression. And it's nice to have a concept, but you didn't explain theoretically. Sir William's been knighted in England for his advocation of doing artificial cisterna magna for searings. And now you said you don't do anything without any explanation. And more surprising is that when you do that, the scoliosis in this dorsal spine is improved. Well, you should be take Nobel Prize, not be knighted in England. I mean, you have to tell us the theory for that. How does it occur? How your magical invention does that? I mean,
now you please listen to this. Now I will give you my explanation, okay? One thing is, whatever statements I have made, whatever statements I have been making are all published and all are heavily in literature. I have got at least 50 articles on this subject, and I will like you to read many of my articles. So you know what? I was also doing decompression earlier in my life, and as I showed you. And I was the first one in the literature in 1998, where I measured the posterior cranial fossa volume, and I showed that article. And I showed that foramen magnum decompression without dural decompression is a good operation in 1998. But as I matured in my business, as I matured in my learning process, I identified that it is not, foramen magnum is not tight in many of these cases. Foramen magnum is, there is lot of subarachnoid spaces. So then subsequently I published another article where I mentioned that
But
vertical.
just forgive me for interruption. I mean, one of your picture, I've been looking carefully to your images. I mean, there's no dislocation, nothing at all, but you have to do a far lateral CT scan images to see the subluxation or dislocation or asymmetry in the facet joint, and nothing there. I mean, the whole thing, you mean the main pathology starts from the facet joint, far lateral. So this means that not every case we come across, whatever syrinx or any quadriparesis or the symptoms, we have to look at the facet joints far laterally between C1 and C2.
Absolutely.
Is that you are really giving the message for that?
Absolutely. Now what I'm saying is, in the presence of Chiari, even if there is no facetal malalignment, even when the facets are aligned, it is an unstable. So that concept which I have introduced is, as you rightly said, it is a Nobel Prize winning concept. And when I come to Egypt, you please give me a Nobel Prize, or Egyptian Nobel.
I will. I'll give you El-Ghandour Prize.
Yes, you must give me prize. When
we
I
have
come.
El-Ghandour Prize.
So, you know what, this subject is being discussed all over the world. And now I have got visitors from several parts of the world, including from Egypt. I'm not sure if my recent Egyptian fellows are there in the audience. I'm not sure, but I'm sure they must be in the audience. And you can actually, you know what, you must, if there is some Egyptian, my recent fellow, Ahmed, are you there? I'm not sure if he's there. Recently, there he was with me. So what I'm saying is, this is a new concept. And I am sure there will be many, you know, it will not be taken up very easily by, at least by senior people. But it is a concept which is completely, absolutely clear in my mind. And this is what I have to say.
Well, we are not objecting. Probably we are fascinated, but we need just a solid concept or solid explanation. Probably I would change my techniques instead of doing decompression. I will follow you. Why not? It looks very easy and nice. And you always do the traction during surgery to open the atlantoaxial facet joints?
No, I
do that always?
No, I always give traction, but traction.
How many kilos do you put on traction?
About, I will say 4 to 5 kilos, depending on the weight of the person. But I must also tell you, I give traction not to open the joint. I give traction. I give traction to keep the head high, and I keep traction to keep the face, you know, floating head. And I, you know, the joint I open during the operation with the osteotome, as I showed you in this.
But forgive me, what do you mean by high? I mean traction. Either you do extension, more extension, or flexion. What do you mean by high? What high means
high.
You mean
it's head end of the table high. The head is in neutral position, means it is not flexion or extension. But the head end of the table is about 35, 40 degree high. I do it because I reduce the venous congestion in that area by head high.
Okay, thank you very much.
What I want to do is, I want to go to the next part of my presentation. And then I want to give you some more revolution. And you will enjoy more revolution here.
Well, we still have some questions in the panel. Do you like to answer now or after your second presentation?
Second, you will have some more questions. And, you know, my friend will have more revolutionary ideas. So let me show you more things, okay? Now I want to show you cranio. You see, I said in the beginning of my lecture that atlantoaxial joint is the most mobile joint of the body. And I want to introduce another beautiful concept, that atlantoaxial joint is the most mobile joint of the body. Atlantoaxial joint is the most unstable joint of the body, this concept. And instability is the mother of spinal degeneration. This is the third concept I want to introduce. I will repeat. Instability is the mother of degeneration. So when we talk of spinal degeneration, we always talk of C5, C6, C4, 5, C3, 4. We never talk of craniovertebral junction degeneration. My recent revolution, Nobel Prize winning revolution is that craniovertebral junction degeneration is a very common form of spinal degeneration. In the year 2010, for the first time in the literature, I introduced craniovertebral junction degenerative osteoarthritis in 108 cases I published. So what I published is that spinal instability results in reduction in the atlantoaxial joint space. That is one thing I published. Second thing is when there is reduction in the joint space, there is buckling of the posterior longitudinal ligament and there is osteophyte formation. So we said that osteophyte formation is not primary, like when we see C5, C6 osteophyte, we say we have to remove it. But what I'm saying is this osteophyte formation is secondary to reduction in joint space and atlantoaxial instability. So these osteophyte formation in the joint and osteophyte formation in the midline is not a primary process, it is secondary to instability. So this is osteophyte formation in the apical ligament. So when you see this osteophyte formation, there is osteophyte formation here. So these osteophytes are not primary, they are due to atlantoaxial instability and you need to stabilize. You see, this is stabilization. I have not done any decompression. So you please see this carefully. So there is an osteophyte here and there is an osteophyte here and there is an osteophyte here. So when there are osteophyte formation, they are not primary. They are secondary to atlantoaxial instability and you don't need to do decompression here. You need to do stabilization here. That is the concept. Another fantastic concept, and you must try to understand, when there is posterior longitudinal ligament ossification and there is ossification in the region of apical ligament, they are indicators of atlantoaxial instability and craniovertebral junction malalignment. You need to do craniovertebral junction stabilization in this situation. There is no need to do decompression. That is my revolutionary concept. Another beautiful thing we said, that this retroodontoid ligamentous hypertrophy and retroodontoid pseudotumors are not primary processes, they are secondary and they are like osteophytes and they indicate the presence of atlantoaxial instability. You do not need to remove this, you need to do stabilization. So retroodontoid mass is an evidence of craniovertebral junction instability. You do not remove this, it will automatically disappear. So my concept is that osteophyte will automatically disappear if the segment is stabilized. So atlantoaxial instability is the atlantoaxial instability is the cause of retroodontoid mass. And when you see retroodontoid mass, you need to do atlantoaxial stabilization. Retroodontoid cyst is a manifestation of unstable atlantoaxial joint. You do atlantoaxial stabilization, the cyst will disappear. There is no need to remove the cyst. That is my concept. This was published immediate, and this cyst can disappear in the immediate postoperative. This scan was done in the immediate postoperative period, the cyst disappeared. There is a huge cyst here. Everybody in the world will do cyst removal because it, do cyst in it disappears. Very easily you can demolish the cyst. But you don't have to do this. You have to treat atlantoaxial instability, and you do stabilization. The cyst will automatically disappear in the period of 2-3 months. So multi-level spinal degeneration, you see multi-level degeneration, there is an osteophyte present here, there is an osteophyte here. This osteophyte and this osteophyte have the same genesis. It indicates atlantoaxial instability, and it indicates the need for atlantoaxial stabilization. You see this pannus. In rheumatoid arthritis, we all know rheumatoid arthritis, that there is a pannus. So pannus, we have said that this is due to vertical reduction, vertical spinal instability. You distract and fuse, the pannus will disappear in the immediate postoperative period. I published this in the year 2008, and there is no need to remove the pannus. So that is another beautiful concept that you may like to, whether you agree or not, that is your thing, but it is all published in the literature and in very heavily published. So there is this dislocation, you distract and fix, and you see this, there is a rheumatoid arthritis, the whole thing has gone in. There is no need to do decompression. There is need to do stabilization. That is my concept. And this is published, Cranio-Vertebral Junction. There is no need to remove pannus. There is no need to do any kind of bone decompression. Now I want to introduce to you to my young and old Egyptian friend, a magic. Another Nobel Prize, this Nobel Prize number 2. My concept is spinal degeneration is due to an unstable spine. Decompression is not necessary. And in spinal degeneration, atlantoaxial instability is also very common. Now let me show you some cases. Is instability the nodal point instability, the nodal point of pathogenesis of both spondylosis and posterior OPLL and degenerative spine? Now you see this here, there are multi-level spinal degeneration. Many people will do laminectomy. Some people will do discoidectomy here, discoidectomy here, discoidectomy here, or corpectomy. What my concept is that these osteophytes are related to vertical facetal instability and are secondary in their secondary manifestation. You don't need to remove the osteophyte, you need to stabilize the spine. That is one thing. You see there is no compression here, but you see the facet. There is a facetal instability. This patient will never improve in his clinical symptoms unless you stabilize the facet. So what I am doing is, I am doing atlantoaxial fixation and subaxial fixation. There is no decompression from front and there is no decompression from behind. You see another beautiful case. They are controversial. Maybe you agree, maybe you do not agree. That is upon you, but these are all heavily published. You see there is multi-level spinal degeneration, and you see there is a facetal instability. There is no compression. You need to do atlantoaxial fixation and subaxial fixation, and you will create a magic. You will create a magic. Cervical spondylosis in patients presenting with severe myelopathy, atlantoaxial instability is almost always present. So multi-level spinal degeneration, severe myelopathy, this patient came on a wheelchair. You do fixation and you will give a new life to this patient. The osteophytes will eventually disappear slowly. You see these osteophytes have reduced in this patient. I'm not sure if you can see it properly, but they will eventually reduce. Another remarkable, magical concept is the treatment of OPLL. You know, we all treat OPLL by decompression. So this is the OPLL. This is the OPLL. You will like to do corpectomy here and you will like to remove this. You will like to do multi-level corpectomy, or maybe some people will like to do decompression from behind. What I'm saying is that OPLL is a manifestation of spinal instability and you need to do stabilization. This OPLL you do not need to touch. So multi-level spinal instability is the cause of multi-level OPLL. No need for decompression. Only fixation is the treatment, and in many cases, atlantoaxial joint is the issue. So earlier in my series, I described for the first time oblique corpectomy. I described long time ago, this is the article. I described that we should do oblique cuts in the bone and then remove the OPLL. This I have described. So I was doing decompression earlier. So this is the corpectomy I had described, and I was, you see, this is after corpectomy, and there is no stabilization, which we were doing earlier. But now I am saying that atlantoaxial instability is the cause of high OPLL and even low OPLL. So ossification of the posterior longitudinal ligament, my concept is that craniovertebral junction and spinal stability is the treatment. So there is multi-level OPLL here, and I have done multi-level stabilization. There is no decompression at all, no corpectomy, no discoidectomy, no OPLL resection, and believe me, a revolution in the treatment of OPLL, revolution. You see this multi-level OPLL, you will like to come and do multi-level corpectomy and all these kind of things, you will probably demolish the person, in my estimation today. I used to do corpectomy. I described oblique corpectomy. But today, in such a case of high OPLL, there is atlantoaxial fixation and subaxial camelus technique, transarticular fixation, multi-level stabilization, no decompression, and you give new life to these patients. So atlantoaxial and subaxial spinal. What I will, Nasir, I will like to do is, I will like to give a complete presentation on this degenerative spine on some other occasion. Today, I am just introducing the concept, but I will give a detailed explanation. If you please allow me to give another lecture on some other occasion, and I will like to talk on this subject.
Of course, we are honored. We will do this.
There is a spinal kyphosis. Spinal kyphosis, many people will do corpectomy and all those things here. But what we have said is that this kyphosis is a manifestation of an unstable spine. You do stabilization only, no corpectomy, no nothing, no laminectomy. And this is published here, the role of atlantoaxial. You see there is atlantoaxial instability here. You have to do atlantoaxial stabilization, and you have to do multi-level spinal stabilization. Another thing is, I'm not sure if you know this disease, Hirayama disease, which is very commonly seen in young adults, and they come with deformities of the hand and deformities in the finger. And there is, you do flexion, there is a mass behind the cord. So this is known as Hirayama disease. And this is commonly seen in, at least in Asian countries, it is very commonly seen. I'm not sure in Egypt. And the young people come with this kind of hands, and various kinds of treatment are recommended. And we identified central instability and subaxial instability in these cases. And you see the hands have recovered after surgery. So this is another treatment of this issue of multi-level instability. So there can be Chiari and Syrinx and Hirayama disease, and you have various kinds of treatment for this, but only stabilization, no decompression. So now I am saying for sure, and without any controversy in my mind, I know you will have controversy. I know many people are doing decompression and they are having good, significantly reasonable results, and they will say, no, I am doing and I am having good results. But I am saying clearly, I'm saying positively, and I'm saying without any doubt, and I am saying that I have treated Egyptian patients with this kind of stabilization when they have failed foramen magnum decompression. And I am saying that there are many young Egyptian doctors who are in the audience, I have seen their name, who have come and seen this, that Chiari is not bad. Syringomalia is not bad. It is for the patient, and it is formation, it is not malformation. So basilar invagination, syringomalia, Chiari are not malformations. They are protective phenomena. Atlantoaxial instability is the cause. and atlantoaxial stabilization is the treatment. Occipital fixation should never be done. Atlantoaxial stabilization should be done. Foramen magnum decompression should never be done. Transoral decompression should never be done. These are all historical operations. Thank you very much, my dear friends. So now I know there will be several questions, and I know there will be some aggressive questions, and I know I'm at the receiving end. But I can tell you, my dear friends, we should keep our minds open. We are students of neurosurgery. We are learning neurosurgery. New concepts will emerge, and new concepts will eventually take over the world of neurosurgery. And there will be new Nobel Prize winners. And one Nobel Prize
we know
winner
you very well. You always come up with something new and sometimes shattering for our mind. So we're expecting you to receive a Nobel Prize very soon, dear. But you
no, I
still
don't want
have
Nobel Prize. I don't want Nobel Prize. I want a Nobel Prize from the Egyptian Society.
Well, I will give you a Ghandour Prize from Egypt when you come.
Goel, we have several questions in the panel. Let me say the first question. Do you like, this question is from Dr. Ali Malkok from Turkey. Do you have reduction problems due to fusion in adult patients?
No. If there is fusion, you see, there is, most important thing in this operation is you have to identify when there is fusion and when there is no fusion. If there is a fusion, see, another statement I'm making, you must carefully note down this statement. Instability is the issue, and stabilization is the treatment. That is the basis. If the patient is already fused, it means it is not unstable. Then you don't need to fuse. And this kind of fusion is very rare. You see, we used to call atlantoaxial fixed dislocation. We used to always call it fixed because we thought it is fused. But it is very, very rarely fused. It is almost never fused. Atlantoaxial joint, you see, it is almost never. I have never seen a fixed dislocation. I've never seen a fused joint. And if you are seeing fused, then you don't need to, then you cannot, then if you are seeing bone along the facets, in the facetal articulation, if you are seeing bone, then you have to really discuss this issue.
Okay. Another question from Dr. Muhammad Al-Qazzaz from Suez Canal University from Egypt. When to proceed to suboccipital decompression in Chiari 2? And
Never.
he has another question.
Chiari 2 is different. Chiari 2 I'm not talking about. I'm talking of Chiari 1. Chiari 2 means there is some spina bifida, some lumbar spine. Those cases I'm not saying. I'm saying of a regular Chiari where we do foramen magnum decompression. Chiari 2, Chiari 3 are different issues completely.
Okay. He has another question. Why you don't like to use coagulation?
No, that is my surgical technique. Ehab has seen my technique. Ehab knows how I do my cases. I do, sometimes you will not believe, I do 12 or 13 major cases in one day. That is my technique. And I wish many of you young people should come and see that technique. And Ehab, you want to say anything about my technique, Ehab?
Yeah, I still remember, I still remember working with Dr. Atul Guil. He doesn't use bipolar. Even in cranial surgery, when he go into dissection in atlantoaxial dislocation, vertebral venous plexus, he just put cottonoid and gel foam and expose the other side, and they return again. It become coagulated naturally, not using bipolar for diathermy.
See, bipolar and all are very important instruments. I'm not saying bipolar you should not use, and I'm not saying that. But I am saying that you should not continuously, unnecessarily go on coagulating and burning and charring and monopolar. Monopolar instrument is, I don't know this instrument now, monopolar. But bipolar I use very infrequently. For acoustic tumor, I use coagulation only very little at the end of surgery in the inferior pole of the tumor. My concept is if you coagulate inside the tumor, that is waste of time. And if you coagulate outside the tumor, that is a technical mistake. In pituitary tumors, if you go on coagulating, that is absolute technical mistake. So that is my style of surgery. I wish some more Egyptian people can come and spend some time here. Like many of Egyptian friends I know, including very senior Egyptian. I'm not sure if Ahmed Higazi is there in the audience. Higazi? No. Higazi is a senior Egyptian neuroscience.
Yes, I know he's working in Cairo University. He's our colleague. I will try to call him if it's possible to join until we proceed in discussion.
Yes.
You wanted to see a comment or question to Professor Guel?
Yeah,
I think you sent.
I have question to my Professor Atul Guel about Chiari malformation. Before I worked with Dr. Atul Guel, I didn't know anything about that Chiari malformation. We should search for atlantoaxial stability in this identity. But after working with him, I was oriented about this problem. I still remember after returning from India, like 2 to 3 years after returning from my fellowship with Dr. Atul Guel, I have a case that performed Chiari decompression with another neurosurgeon, and the patient improved for 2 months. And after that, he became deteriorated more and more, even more than preoperative. Patient visited many neurosurgeons, and they are telling him nothing to do. He performed the posterior fossa decompression as usual, foramen magnum and C1 removal. The patient came for me. I performed for him flexion and extension MRI. I saw that the patient has decompression and extension view. And this was the first experience with me after about Chiari formation, about atlantoaxial instability in Chiari malformation. I performed atlantoaxial fixation for this patient, and this patient much more improved, and the patient returned to his normal life. My question to my Professor Atul Guel, in Chiari malformation type 1, if flexion and extension MRI and CT and X-ray is atlantoaxial is stable, should I proceed also for C1, C2 fixation?
Yes, my answer to that question is you must do atlantoaxial fixation in all cases of Chiari 1. All cases. And to
you mean flexion and extension MRI has no role? Chiari type 1, go to fixation.
No need. You see, I was doing it. When I started doing, I used to do all these kind of imaging, flexion, extension, dynamic imaging. I introduced a classification of facetal malalignment, which I showed. But now, when I see Chiari, you see many of these patients, I must tell you, many of these patients come with breathing disturbance, voice disturbance, pain in the shoulder, pain in the hands, paresthesia in the fingers, sleeping disturbance, sleep apneas. Many of these things happen. They cannot sleep straight. I can tell you, see, I'm not, I am working in a very poor public hospital. I am not a rich man. I am not talking from this pedestal. I am not an, white man or something like that. I am a very, on the ground. I am telling to my Egyptian friends and to my Egyptian brothers. Chiari malformation treatment, foramen magnum decompression is a negative operation. Don't do it.
I understand. According to my experience, the patient improved very well. Yeah, really. But
I am now having a very big experience since I published about 10 years ago in Journal of Neurosurgery. I am getting patients from all over the world with failed Chiari, failed treatment. And I have got an experience of failed Chiari treatment of about 60 patients from all over the world. And my treatment, my experience of Chiari is now with atlantoaxial fixation is more than 400 cases. Recently, I published in Journal of World Neurosurgery Journal. You please read this, my article.
My second question to my dear professor, in cases with high arched vertebral groove, which constitute about 15% of axis vertebra, what you approach to perform transpedicular screw? For me, I can perform translaminar screw, and I feel in all patients that have high arched vertebral groove in the CT, axial cuts preoperative. This patient have capacious lamina, can tolerate translaminar screw. But I saw you performing special entry point for high arched vertebral groove. You drill and you produce your screw directly into the access body. You can tell us about this.
See, high vertebral artery is very common. As you said, 15%, 20% high vertebral artery. But even when the high vertebral artery is there, you can, identify medially a good point and you can introduce the screw medially, even in high vertebral artery. But now what I'm doing is little bit, to drill the thing and mobilize the vertebral artery in rare cases. It's not required frequently. And you can go medially and, you can do it in 100% of cases, even when there is high vertebral artery. And if you cannot do, suppose you cannot do, I described I described spinal process screw. I showed one article, spinal process screw, laminar screw in 2004.
Yes.
I never do it now. I never do it. I always do lateral mass fixation. Yes, even if it is very high.
According to my experience in high arched vertebral groove, I performed the translaminar screw. It's a mechanically strong screw, and the lamina can tolerate up to 22 to 25 millimeter length of the screw. I think it's biomechanically strong screw, and I can reduce in it, I fix in it.
Another question in the panel. I have you proceed. Okay, I'm sorry. You want to proceed?
No problem, Doctor. I think also translaminar screw is much more easier for young neurosurgeon. I think transpedicular screw with high arched vertebral groove will be difficult for them. So I advise them, forgive me, dear professor, to do when they discover high arched vertebral groove in the axial cuts of the CT preoperative, to perform directly translaminar screw. About trans screw, I don't believe in it.
You have just listen.
Yes.
See, now this question of young neurosurgeon and old neurosurgeon is there.
Yeah.
I described C1, C2 fixation when I was 27-year-old in 1987. I described this technique. And I have a feeling that those who are young or old, they cannot say, or inexperienced, they have to get the experience, they have to learn, and they have to do the best technique. And they have to do the most optimal technique, because if you compromise on your fixation, you lose the chance of giving a new life to the patient. You give new life, completely new life, if you do good fixation. If you say, no, I cannot do because it is difficult, because I am inexperienced, because I cannot do, because I will now do occipital fixation, that is not occipital fixation, and other things are not good. They are suboptimal. Never do that.
We have another question in the panel from Professor Faiz Obeid. He is the president of the Jordan Neurosurgical Society in cranio cervical instability and basilar invagination. Is it essential to open the joint or to do traction before fixation?
Now, you know what? I had done one live surgery demonstration in Jordan. I'm not sure if our president was there. I had done 2 cases in Jordan live. And basilar, and I must also tell you that I have treated several patients from Jordan for basilar invagination. I think Jordan has a lot of basilar invagination, I must tell you. And I treated one oldish man, not oldish, about 60-year-old man with basilar invagination. And his daughter was not walking properly. When she came to India, her daughter was not walking properly. And I did her MRI of her daughter, and she also had basilar invagination. So I treated her daughter also, both from Jordan. So I have to tell you that whenever you are doing atlantoaxial fixation, whether there is basilar invagination or not, you have to open the joint. You have to introduce bone graft in the joint. unless it is extremely difficult, then you cannot do it. Then you have to do fixation with instrumentation. But if possible, you have to do, because that gives you a very good bone fusion possibility. That is my answer, Nasir.
Goel, I called Ahmed Higazi and he's able to join the meeting now. I think he's with us inside the meeting and I promoted him to be in the panel. Ahmed, are you here? Ahmed Higazi.
Yes, Dr. Nasser, I'm here.
Ahmed, you missed the webinar, and I was telling that Ahmed Higazi was my first fellow from Egypt. And
Yes,
then
yes,
he came
definitely.
again. I think he came again to spend some more time with me in my department.
Yes,
and
definitely.
And Ahmed, I was just telling about bipolar. The question was that I don't use too much bipolar and I use it very infrequently. I would like you to give some your experience with your training in my department.
Well,
I know you are a very senior man now.
I've spent a very beautiful time at your department at KEM, and it was one of the best times in my life because I was able to have a glimpse at your mind, and you gave me an opportunity to re-understand the whole of neurosurgery, actually. What you taught me was not just neurosurgery, but was also a way of life. You taught me how to be a human being. You taught me how to be a man. And what you gave me in neurosurgery, no one else has ever given me, because you told me that a lot of things that I thought were impossible were actually possible. For example, the use of the bipolar, because the bipolar is always there, but you very, very infrequently use it, very rarely use it. I've never seen you use the bipolar, not even once, in a case of C1, C2 fixation. I've learned a lot from you, and practically everything that I do in neurosurgery right now is something that I have in one way or the other learned from you. So I will never forget the time I've spent at KEM, the endless times you took me with you to Lilawati, the number of times you took me home with you, with Mrs. Gowell, and the things that I've learned from you, and her food. I can never forget her food.
Ahmed, there is a very big proposal. You must support that proposal.
Definitely.
That Osama is putting up, and he is giving me a Nobel Prize from Egypt.
No, I think Nobel Prize from the whole world. The least the world can offer you.
Thank you very much, Ahmed. I wish you come again, and I wish we meet again, because
Definitely.
I remember you as a young boy. I remember you had very elaborate training in various big centers of the world, and you spent several months with me, and I know how ambitious and how strong and how energetic you were. And I think the next time you came with Ehab. I think you came with Ehab the next time, second time.
No, it was with Dr. Mohammed Isi the second time that I came. Yes. And we've spent a wonderful time.
Thank you, Ahmed, for coming. Thank you very much for these kind comments. I know, Ahmed, that you are in the Red Sea beach now, and we can see the image. And when I called you, you were able to join. And so thank you very much for coming, Ahmed. Thank you.
Thank you very much, sir.
We have another. Thank you, Ahmed. We have another question in the panel. This question is from Libya. Do you like to use traction intraoperative in any case, or it depends?
Every case, I use traction intraoperative. I do not use preoperative traction. I do not use postoperative traction. I use traction only intraoperative. That is my answer.
Okay,
and
another question.
Traction, I don't do to traction. I used to just stabilize the head.
Okay, another question from Turkey. What about the rod you are using in subaxial area in ossified posterior longitudinal ligament cases? Is it rigid or dynamic?
I'm not using rods. I'm using transarticular screws, the technique which Camille had described in 1972. And I find that technique very simple, very straightforward, very quick, and very strong, because facets are the strongest part of the vertebra, and facetal fixation is the fulcrum of the movement, and facetal fixation is the strongest. That is my understanding. And
Thank you, Goel. The last question in the panel from Jordan. Any case of CT guided or only you are using routine X-ray image?
what CT guided during operation, image guided surgery, navigation assisted, right?
Yes.
I used navigation sometimes, but I don't think it is absolutely necessary. But if the person is not very experienced, as Dr. Ihab was saying, if the person is not very experienced or very familiar, I think navigation is a very good tool, and where navigation can be and should be used, at least in the initial cases, is a very fantastic tool.
Okay, we finished answering all questions in the panel, but we can listen to any comments. Ihab, do you like to say something?
Yes, I wanted to add an additional answer for the last question. Yes, I think only fluoroscopy is enough in craniocervical surgery, because you have to read the radiology preoperative very well. You have to read the dimension of the atlas and also the pedicle lamina and bars of the C2. If you understand this very well, and if this three-dimensional view are well instructed in your brain, you can put the screw very simple, even without fluoroscopy. This is my belief about craniocervical surgery.
Any comments? Professor Osama Al-Ghannam, Professor Abdul Hafiz, Professor Ali Madawi?
I think Professor Goel has enough from us, but I wanted to ask Dr. Ali Abu Madawi, but I'm sure if he's there or not, I don't know. I wanted just to ask him.
He's not here, doctor.
I think he is left.
He is online, but the mic is not working. No, he's online.
No, I think he wrote that he is left.
Oh, really? Okay.
5 minutes ago, yeah. Well, I probably will ask him again, but we thank you very much indeed. And I enjoyed all the lectures, and I must say, especially seeing my old dear friend, Professor Goel. He's really a good man and always fantastic, comes with new ideas. So thank him for joining us.
I can also tell you one thing, Dr. Sameh, who is a young neurosurgeon, he's organizing one meeting very soon where I am giving a 30-minute presentation. And I am going to talk on degenerative spine and OPLL in that presentation of Dr. Sameh. And he's, he's become very famous now in the whole world, Dr. Sameh, with the webinars that he's organizing and with the kind of, following that he has throughout the world. So I hope you can join me I think in 1 or 2 weeks, I am going to present in his webinar on degenerative spine and OPLN, and I hope and I wish you can join me.
Just
please send me the flyer. Send me the flyer, Goel, so that we can disseminate it in Egypt and Africa.
Okay, okay.
Professor Osama?
Okay, thank you very much indeed. I don't have any more. And I thank everybody sharing with us, and especially the lecturers for their very illustrative and good lectures. Thank you very much indeed.
Thank you very much.
And what about the rest of the program? Professor Goel, do you like to present something else or to show us some videos? Or
no, I have videos. In the meantime, you continue. I will find some video where I will show you a mobilization of vertebral artery. Okay, so I will just find on my computer. In the meantime,
can you help make his presentation? He's going to squeeze it in 10 minutes, and then we will you can present your video. Okay.
Okay.
Yep.
Yes. I'm preparing.
Take your time, okay. You have green button at the bottom, and you can
Yes,
share
yes.
your screen from this one.
I
think
will
you're
do.
already sharing it.
Yeah, yes.
You're already sharing it. Okay, okay.
I wanted to hurry up because I know that I have short time just to talk for simple things. Philosophy of Atlanto-axial surgery. I changed the name from surgical experience on Atlanto-axial reduction and fixation. This word provided by Dr. Atul Gouil in his talk also, because it's not a simple surgery. It is not a disc to remove or a skull base to approach. It's this type of surgery you have to think about the radiology that you are looking for, to ask for more radiology, and then thinking what I will do, how I will reduce, what extent I will reduce, and how to fix. I classify my talk to introduction. I wanted to hurry up to give a chance for my professor Atul Gouil to show his video. I want to go directly to not historical background. This is historical background about C1, C2 fixation. I want to talk little bit about this point. Still, there is a neurosurgeon performing occiput to C3, C4 fixation, bypassing the problem on the C1, C2, and performing C1 laminectomy. And they are imagining that they are doing is craniocervical surgery. I think this is not allowed in modern craniocervical surgery. To bypass the segment with instability and performing more additional instability in it by drilling or removing the posterior arch of the C1, you put the patient in biomechanically weak fixation, and this patient is exposed to more and more problem, and I saw many problems like this. In modern neurosurgery, you have to go to C1, C2 fixation. C1, C2 fixation is not only screws. Because when Dr. Atul Gouil described the C1 posterior lateral mass screw, this has changed the philosophy of the Atlanto-axial surgery, because we work on the level that is affected, so we can reduce, then fix. Philosophy. My philosophy, word philosophy, means deep thinking. Deep thinking about proper looking for the radiology, and then asking for additional radiology. Usually I ask for MRI, flexion and extension, and X-ray and CT. They aim to achieve two goals: reduction and fixation. In the beginning, when I'm doing craniocervical surgery, I was completely minded by C1, C2, how to insert the screw, surgical exposure, and decompression. After visiting my professor Atul Gouil, I learned reduction. Reduction without decompression, without bone removal, just to reduce. After this will already decompress the spinal cord, and this will treat the initial problem. So the first goal, after deep thinking and the proper reading of the radiology, to know, is this dislocation irreducible or irreducible that can be reduced intraoperative? What is the meaning of the intraoperative? Because when you are doing flexion and extension MRI, you have some fractures are reducible as it appears in case presentation, and some fractures or dislocation which is irreducible. Reducible in anterior dislocation. This word is for young neurosurgeon. Anterior dislocation of atlantoaxial spine can be reduced in extension. You can see in MRI in extension, it is reducible. But posterior dislocation of atlantoaxial spine, it will be reduced in flexion. So take care when you initially looking for the radiology. If you have posterior dislocation of atlantoaxial spine, which is rare, don't put neck collar for the patient, because it will put him in extension. This will add more compression of the spinal cord. And I saw many, I still remember patient coming for me with posterior dislocation, and his power was intact after accident, but neck collar make him more and more deteriorated, because it puts the spine in the direction which compressing the spinal cord. This is why I'm using the term philosophy. You have to take a look for the radiology. You have to understand the radiology. After that, if you have irreducible fracture, what you will do, you have to dig deeply again for the radiology. If this fracture, there is a compressing mass, or there is fracture that malunion for it and fusion between the lateral mass and the axis, which will need anterior decompression, then posterior reduction and fixation. Or It is irreducible because it needs only intraoperative dislocation or opening of the C1, C2 joint. In most of the cases, it can be an irreducible dislocation. It can be reduced only by posterior approach. Now, anterior transoral approach, as Dr. Goel said, it is limited. For my opinion, it is limited for cases with the anteriorly compressing lesions or for fracture that fuse in abnormal way. I will show in the case presentation, it will be much more better. How to reduce this is when after reaching the decision whether to reduce by posterior or anterior then posterior. During reduction, you have to think about the three ways: axial, anteroposterior, sagittal, and coronal, which is rotatory. The second item after reduction, how to fix, how to put the screws. Again, proper reading of the radiology to know the dimension of the atlas. Three-dimensional of the atlas should be in your mind when you are inserting the screw. Yes, I know there is a fixed point of entry, fixed direction, but the size of the atlas is, and the dimension is changed from the patient to other. So you have to put the three-dimension of each patient in your mind when you are putting the screw. This is much more better than using intraoperative neuronavigation. It will make it for you much more easier. Again, the second, how to fix, is very important in the access screw. You have to read the radiology very well because most of the neurosurgeons consider that access screw is only transpedicular screw. No, it is not correct. There are access screw, transverse screw, transpedicular screw, translaminar screw. Transpedicular screw is the biomechanically strongest screw. We know this, but we have the problem of high arched vertebral groove. High arched vertebral groove, as it appears in this photo, the pedicle size is small. Pedicle size here is below 3 millimeters, the width of the pedicle. It is difficult to accept the screw, and also the difference between normal and the abnormal and the high arched vertebral groove, which is in the 15% of the population. I don't say this is impossible. You can put it, as Dr. Goel said, you can drill and mobilize the vertebral artery and insert your screw directly in the vertebral body. But at least you have to know that this patient or this site, there is high arched vertebral groove. What I will do, if I can do it, I can proceed to another type of screw. I don't use transverse screw, but I use translaminar screw with and transpedicular screw. Surgical technique. This part is for young neurosurgeon, how to expose my wound. I classify my wound usually into three parts. The upper third to expose the occiput. The lower third to expose the C2, C3. The middle third to expose, then starting dissection, this is the last part to expose the posterior tubercle of the posterior arch of the C1, then dissect laterally to reach the vertebral groove. And after that, I work from the bars interarticularis of the C2. Bars interarticularis of the C2 deliver me to the C1, C2 joint. Here we will find the C2 ganglion. I know Dr. Attilo Goel mentioned that he doesn't cut it, but I cut it routinely in all my cases. This provides me this wide exposure. Now, the lateral mass of the C1 is completely exposed. The joint is exposed. I can open it. I can reduce. I can put bone graft inside it. Now, the entry of the screw. This is cadaveric dissection performed in anatomical department, Qasr Al-Aini Hospital. It includes three types of the screw. This is transpedicular screw. At the intersection between bars interarticularis of the C2 and lateral mass of the C2, at the junction between lateral third and medial 2/3, this is my entry point, directed 40 degree medially, 15 degree rostrally. This will provide you into the pedicle of the C2. Here is the transverse screw. Transverse screw started 3 millimeters above the inferior edge of the C2 facet and directed 60 degree rostrally. This is the cadaveric bone showing the three types of the screw inside the axis. This is the transverse screw. Transverse screw is 3 millimeters above the posterior edge of the inferior facet and directed 60 degree rostrally. We notice that extension of the transverse screw is the transarticular screw. Here, if this screw is completed, you can hit into the lateral mass of the C1, which is called the transarticular screw. But the problem is this screw is carry high risk for the vertebral artery in cases in which there is not irreducible fracture, not optimum alignment of the C1, C2. So I don't use it at all. I use the transpedicular screw. This is the transpedicular screw, and this is the translaminar screw. This is the translaminar screw. Translaminar screw is the easy screw and biomechanically strong screw. You can insert a screw-like length about 25 millimeter inside the lamina. And I wanted to tell any neurosurgeon, especially young neurosurgeon again, you have to read the radiology before inserting the screw. I noticed that when the patient has small pedicle, usually has capacious lamina. Of course, many cases has capacious lamina and capacious pedicle at the same time. But when you have a high arch vertebral groove, for sure, I found that the lamina is capacious, and the vice versa. When the lamina is small, the pedicle doesn't have the anomaly of high arch vertebral groove. I think this is a gift from Almighty Allah Subhanahu wa Ta'ala. This is also cadaveric photo. The intraoperative photo. This is the case presentation. Case presentation, I wanted to hurry up, but I want to say, getting 3 cases on the first 3 cases, this was my early experience about craniocervical surgery. Before working with Dr. Atul Gouil. Before working with Dr. Atul Gouil, I was minded how to insert C1, C2 screws, how they decompress. But after working with him, I was completely minded about reduction without any decompression. So in the beginning, in the initial 3 cases, you will find that the reduction is not optimal. Of course, the surgery was successful to good limit, but in the rest of the cases, the result is much, much more better. It's a young girl with the anterior atlantoaxial instability ostentinoid. This is flexion and extension MRI. Screw, transverse screw. In the beginning, I used transverse screw and the lateral mass screw on the atlas. You saw that there is decompression on the posterior arch of the C1, and the reduction is not optimal. The patient improved, but I think if I'm performing this case now, I will reduce only without decompression. Second case, it's the female patient, 50 years old, with the spastic quadriparesis. It's fracture odontoid. This is flexion and extension MRI. It is a minimal reduction during extension. This is how to read the radiology preoperative to know the dimension of the C1 lateral, the dimension of the pedicle, and also we can notice here that there is a Jefferson fraction, associated Jefferson fraction. In this case, transpedicular and lateral mass, atlas lateral mass screw was inserted, and also cross connector was done to correct the Jefferson fraction. This is pre and post-operative sagittal CT dimension. It's much more improved, but again, if I'm performing this now, it was like 9 years ago. I will perform much more better reduction. I will go directly to case number 4, which after gaining this experience of how to reduce. This is the female patient with fracture odontoid, anterior dislocation of atlantoaxial joint. This is extension CT, reducible and extension CT. This is how to read the CT. This is what I'm talking about. The lamina in this patient is not capacious enough, but you saw the pedicle, there is no vertebral groove anomaly. In this case, this is the flexion and extension. The patient is reducible in extension. I bought transpedicular screw and C1 lateral mass screw. This is intraoperative view before reduction. I usually put the patient in the headrest, then putting the screw in neutral position. After, and the patient, of course, in the patient which have preoperative MRI and X-ray that reduced easily in extension. After that, I do intraoperative extension of the head before putting the rod. This is the view after inserting the rod and the complete reduction. This is 2 image intraoperative on fluoroscopy. One before intraoperative reduction on the right side, and the second one after complete reduction intraoperative without any decompression procedure. And this is CT post-operative with complete reduction and the insertion of the screw transpedicular and into the lateral mass of the C1. This is another case with a young boy with atlantoaxial instability due to osodontoid after accident. This is the size of the lamina and size of the pedicle. The patient is any type of screw. There is no high arched vertebral groove. It's decompressed or returning in the extension position. This is flexion and extension MRI. You see that there is complete reduction extension. Again, intraoperative, putting the screw, C1 lateral mass, translaminar screw of the C2, and the intraoperative reduction by extending the head. Look, extending of the head, returning to atlantoaxial to the normal dimension. The difference. This is before reduction, inserting the screw. This is after the reduction. Reduction is just extension of the head. Because again, I have the problem in the anteroposterior. But if I have another problem in the sagittal plane or on rotatory plane, I can correct accordingly. This is the post-operative view and about the C1 lateral mass screw and translaminar screw. This is another case with the mass compressing the cord anteriorly. This is another issue. In this mass, I have to read the radiology. I can't go just posterior. In this cases, which is one of the limited cases in my study that need anterior approach. I go and this is the mass destructing the odontoid and lateral mass of the C1. I go anteriorly, removing the odontoid and the anterior arch of the C1, and then posterior reduction and the C1 lateral mass and transpedicular screw. This is the post-operative. The cord is completely decompressed and the atlantoaxial is reduced and fixed. This is another case of structural odontoid. I want to explain simple thing in this case. In this case, I have to correct just not in anteroposterior only, but we have there coronal dislocation, rotatory dislocation. So I have to correct both. This is why I'm saying philosophy. You have to read the radiology very well and you have to apply it intraoperative. Intraoperative, I inserted the screw in the lateral mass of the C1 and insert translaminar screw. After that, I performed extension of the head and rotation of the head to the opposite side. This is why the fracture is corrected, returning to the normal position. This is the case of Chiari malformation, and again, Dr. Atul Gouil. If I didn't visit him, I can't manage this case. This case coming for me, I said before, he performed Chiari malformation with another neurosurgeon, improved for 2 months, then deteriorating. And he asked many neurosurgeon, nothing to do for him. But when he come for me, I performed for him flexion and extension MRI. You see, in the flexion MRI, there is a compression in the cranio cervical, to the brainstem and the spinal cord. And in extension, there is a reduction. Of course, Dr. Atul Gouil telling me now that he performed in all cases of Chiari malformation. No need to perform flexion and extension MRI. This case, fixation was done through the C1 lateral mass screw and translaminar screw, and this patient improved very well. This is another case when to do anterior approach. In this case, we have fracture of the odontoid, and this fracture is fused with the anterior arch of the C1. You have to look deeply for the radiology before doing anything. This is the extension. I expect if I go posterior approach, I will not be able to decompress or returning or doing optimum reduction. So I take the decision to go anterior. I perform anterior decompression, removing the anterior arch of the C1 and the fracture part of the odontoid, then performing a posterior reduction and fixation. Follow-up MRI, decompression of the cord and reduction and fixation. And this is translaminar screw used in this case. I don't have complication regarding morbidity or mortality or vertebral artery injury in my study. It's just minimal complication related to one case of the CSF leak and superficial wound infection. My conclusion is that you have to read the radiology very well before doing craniocervical surgery. You have to know that there is anterior dislocation and posterior dislocation, how to deal with each one. You have to know how to insert your screw and have to select the type of the C2 screw, and then how to reduce intraoperatively. Thank you so much.
Thank you, Ehab, for this great talk. Thank you very much. And now we proceed again with Professor Goel. He wanted to show us some videos.
Okay, I will show you one video. Ehab, can you stop sharing?
Okay.
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 So I will show you one 10-minute video, okay?
Ah, that's good. Okay.
So this is the case of osodontoidium and mobile atlantic. You see, this is high vertebral artery here. You see high vertebral artery? On both sides, it is high, very close to the articulation, very close to the articulation. Now you see, this is my position, head high, under traction. And this is just floating head. So now I am exposing C2 spinous processes here. And I have just started actually. Now you see, please. Subperiosteal exposure, subperiosteal exposure. And on the left side, you will see how I do atlantoaxial stabilization. Here I have introduced in the joint an osteotome. This is a little bit edited tape, okay? This is not an unedited tape like the last one. Now I am opening the C1, C2 articulation. Can you see that articulation? You see, this is the C1 facet. I'm just drilling a little bit of the lateral aspect of the lamina for my positioning of my plate. Now I'm doing under high magnification. Just have a look. I'm opening the joint. You see the joint is open. C1, C2 articulation is open. Then I'm making a hole in the C1 facet. You see here? C1 facet. Now I'm introducing bone graft in the C1, C2 articulation. Quite a bit of bone graft. Here I'm showing only one piece, but I put at least 2 or 3 pieces. Quite a bit of bone graft I introduce. See, here is the vertebral artery. I'm taking my plate very medially. You see how medially I have taken my plate? And polyaxial screws also you can use. But I like to use these plates, which are very fantastic for me. And I can tighten my screw over the plate. Sometimes I use rods also. Now you see here, I am doing C1, C2 fixation. This is the way I normally do. You will see a little bit blood here and there, but I have a feeling that in neurosurgery, we should not be too much scared about blood. Because if we are scared about blood, then we may not be able to do this operation. That is one operation. But you may not be able to do cavernous sinus surgery. You may not be able to do petroclival tumor surgery. Okay, now you see on the right side, okay? And you may not be able to do AVM surgery. You see here, this is on the right side. And the right side vertebral artery is very high. I'm not sure I can show you properly this case, but you just see. Here is the region of vertebral artery. Now this is the C1, C2 articulation that has been exposed. You see here is the vertebral artery. See, if there is a high rising vertebral artery, you can introduce your hole above, here in this area. Now let us see how I mobilize the vertebral artery here. In many of these instances, you cannot, you see, this is venous bleeding, and you may not be able to coagulate. This bone graft introduction, as I mentioned to you, is an absolute method. I have to do bone graft. If I have not put bone graft, then I am not happy. See, that is the hole I am introducing the. Now I am trying to maneuver the vertebral artery. Just have a look here carefully. I'm not sure if I can show you properly. There will be some bleeding, so don't please get restless about it. Now I'm opening the vertebral artery groove. You see, I'm just removing the posterior aspect of vertebral artery groove, that bone. And you see the vertebral artery is inside that groove. And it is pulsating. This is inside the pedicle. Now you see here, I am mobilizing the vertebral artery. Just careful, I'm not sure if I can, if you can see properly, but just try to imagine a bit. You see, that is the facet of C2, which I have, after mobilizing the vertebral artery. Vertebral artery is mobilized under, you see, you can see the pulsations here of the vertebral artery. Now I have mobilized the vertebral artery here, and I have got this facet. Then after protecting the vertebral artery, I'm making a hole in the pedicle and facet of C2. I am protecting the vertebral artery here. You see the vertebral artery is in my hand? And you see the hole in the C2 facet. See, you can do it. I'm not saying that this is required very frequently. But if it is required, you can do it. It is not extremely difficult. I must tell you, it is not extremely difficult. See, once you have tightened the screws, then as I mentioned to you, you have to remove the muscles attached to the C2 spinous process and the arch of Atlas. Very strongly, you have to remove those muscles. You see, it is a little bit red field, but red color is the one which I like very much. Now I am drilling over the arch of Atlas, if it is there, and then I will drill over the C2 spinous process very much. And you must remember that if you have done and completed this operation, you give new life to the person. And that life is in the immediate postoperative period. That is the beauty. That is the beauty. You see, this is postoperative image. And these are some references regarding vertebral artery mobilization. So thank you, my dear friends. And I hope you enjoyed this.
Thank you, Goel, for this excellent video presentation. It's very illustrative, really. And before closing this webinar, I think Ihab would like to say something.
Yes, I want to
I
say,
have.
important.
Ihab, go ahead.
I was lucky and honored to be in the same webinar about craniocervical surgery with my professor Atul Gouil, the godfather of craniocervical surgery, and the professor who taught me again the spirit of craniocervical surgery. I learned from him many things about neurosurgery and also about the life. I still remember the discussion about everything with you, my dear professor, politics, life, everything. Thank you so much, my dear professor.
Thank you very much, Ihab. Thank you very much, Nasser. Thank you, Osama, the president of Egyptian Society. I hope he will remember.
Thank you very much, Dr. I think I'll plan to see you somewhere, sometime in the future, Professor Goel.
Thank you very much, and bye-bye.
Thank you very
Bye-bye.
much. At the end of this webinar, I would like to thank Professor Atul Gouil for accepting our invitation. Thank you, Gouil. You honored us by contribution to this webinar and hope to see you again in another occasion soon. I will send you another invitation to make more extensive presentation and more extensive discussion. Thank you for being too much to answer all our questions. Thank you for being too kind to stay with us all this time. Thanks to other distinguished speakers, Professors Ali Madawi, Ihab Isa, thanks Professor Osama Al-Ghanam. Thanks to everybody for this excellent webinar today. Thank you, Gouel, very much.
Thank you.
Thank
Bye-bye.
you very much, boss. Okay.